good there. So if you look at the hip, so we see the leg bone coming up there to the ball, and then you see a lot of white space. That white space is the joint space. So that's the traction that we're applying across the hip joint. Typically, there's not any space in the hip joint. It's a negative pressure environment, which is why a lot of times you have to apply a fair amount of traction across that hip in order to get some opening in order to be able to do the hip arthroscopy. So the first step with hip arthroscopy is to really access through the, give me the camera here, is to access through the first portal, which is what we call the anterior lateral portal. The tricky thing with hip arthroscopy is actually access to the joint and getting set up for doing the procedure. This is a 21-year-old female. She's had pain. Stephanie might have gone through some of the clinical history, but she's had pain for the last, like 3.5 years. We actually recommended hip arthroscopy for her about 2 years ago, and she continued conservative treatment for it and just didn't quite take her to where she was happy with it. So Phil, what we're looking at is the inside of her hip. So this is right here, this is the femoral head. This is the acetabulum, and this is the labrum. I'll talk a little bit more about the labrum here as we go forward, but what I've done is I've established a secondary portal right now, right here, because again, this is all about accessing the hip joint. Because the hip joint is a negative pressure environment, in order to be able to do the work that we need to do, we need to be able to open up the capsule of the hip, which is somewhat of a debatable, not debatable whether or not we need to do it, but how we manage this in young people, because especially in a young female, that capsule can provide stability in the hip joint. And so if we open up the capsule, especially in a young female, there's theoretical risks of having what we consider to be micro instability in the hip, which is why in these young females, once we do open up the hip joint, actually at the end of the procedure, I'll go ahead and close the hip, which if you talk to anyone that does hip arthroscopy, sometimes we call this a hip closure, sometimes a hip joint closure, sometimes we call it a capsular plication. So what you're looking at, to orient you a little bit, is I'm looking from the front of the hip and I'm looking down the back of the hip. So this is working down towards the ground or towards the buttock area. And I'm just with this knife kind of slowly opening up the hip joint. And then once I've opened it up back there, I'm then going to work my way towards myself here. And you can start to see even that there's some tension on this hip capsule right there. So that's the hip capsule. Good, and I'm working my way towards myself. Let's get the empty blue back. Thank you. Okay, you can open 2 microraptors and you can get a speed stitch open. And then I'm gonna switch my portal back. So as we're kind of talking today, I wanna think about the acetabulum as a clock face. So if you think of the very kind of top portion of that acetabulum, it's approximately 12 o'clock. And then as we go down the front of the acetabulum, that's going to be more around the 3 o'clock position. Hold the camera, please. So that portal, even though it's in the front of the hip, because the patient's lying down, is approximately in the 3 o'clock area or maybe the 2 o'clock area of that acetabulum and of that labrum, Stacy. So again, this is still just opening up the hip capsule. So now I've worked my way I'm working my way towards myself. And so one thing that you can see here is how thick that hip capsule actually is. So now I'm through the hip capsule. So this is the hip capsule. This is the femoral side. This is the acetabular side. If we come down into the hip joint, that little U area right there is typically where the iliopsoas sits. So I'm sure some of you have patients that have hip flexor tendonitis or iliopsoas issues, or what we say popping hip. The popping hip that you can hear is usually that iliopsoas, and I'm not going to expose it in her because it can cause some discomfort, but it's going to be right through this area of the capsule. So maybe just right back in this area, that iliopsoas tendon is going to be crossing the hip at that level right there. At the level of the hip joint, it's approximately 50% tendinous and 50% muscle. You'll probably still sometimes see patients that have had an iliopsoas release, something that, I think we did a little bit more commonly, Shaver, please, a little bit more commonly even 5 years ago. And the idea was that, well, if somebody has some pain in the front of their hip or hip popping, if we release that iliopsoas at the level of the joint, it's 50% tendon, 50% muscle. So it's not a complete release, and that's going to give them some relief. What we found with subsequent outcome studies is that, Scott, that patients will actually get some weakness and some increased pain with doing that iliopsoas, and it oftentimes won't help the popping that they get. So what I'm doing right now is, in order to expose that labrum and we can start to see some of that tearing, is I'm resecting just a portion of the capsule right on top of that labrum right there in order to be able to get to the back side of the acetabular rim, or to get to the acetabular rim on the back side of the labrum, I should say. And so the interesting thing about labral tears in the hip, which are very different than the shoulder, is that you don't typically get a tear where you see a complete detachment of the labrum. It's usually more of an instability issue and pinching down into the hip joint more so than anything else. So you can see she actually has a relatively small labrum, which is somewhat uncommon. In a young female, she's not dysplastic, but she definitely does not have over coverage of the acetabulum, meaning that the cup is bigger and covering things. But you can see her labrum's relatively small. Now, if we come up here, we see that this labrum is a bit angry, and when I push down on it, we see a little bit of detachment. There should normally be no detachment between the cartilage and the labrum right there. But as I push down, we can see some instability and some angriness to this labrum. So what this is telling me in this location is that she most likely has some impingement, but then also probably has some impingement from that iliopsoas. When we get anterior like this, that iliopsoas can cause some of this, this kind of angry looking labrum. As we come up further, more towards 12 o'clock, so to orient you, 12 o'clock, or the top part of the acetabulum, is probably right up around in this area where my shaver is. And then as I push down here, what we can see is something called the wave sign. So I'm pushing down on this labrum, and if you look right there, that's actually the cartilage on the acetabulum that's moving. The reason we call this the wave sign is because it means that there's some delamination or disconnection between that cartilage and the bone behind it. And we think again that this is because of impingement. So if this femoral head, and you'll see as we move through this case, as it comes and starts bumping up against this labrum, it's pinching down and it's causing this loosening of the cartilage. Now, she's very young. Give me the RF. She's very young, so we don't see a lot of detachment, but the progression of this, what this looks like, is that as people kind of go through life, if they continue having this and continue having some pain, that what's going to happen is some of that cartilage is going to start to break away, and they're going to start to get cartilage loss or early arthritic issues in this area. It's a problematic area to get early arthritic issues because the hip, different than the knee, really only bears weight, or the majority of the weight, to a relatively small part of the acetabulum in that location right there. So if they start getting some cartilage loss, they can sometimes have x-rays that look pretty good. However, that they're actually bearing weight on an area where there isn't much cartilage there, causing pain. So what this instrument that I'm using now is this is what we call an RF device, which is basically using kind of some radio frequency waves to clear off some of the tissue that's right on the backside of the acetabulum. So she does not have a big, what we call pincer lesion. So there's two things in hip arthroscopy that we think of. One's called a cam lesion, which is an extra bump on the femur. One's called a pincer lesion, which is a bigger or a bump on the cup or the acetabulum. She really doesn't have on x-ray much of either of those. If I get really critical looking at her preoperative x-rays, she's got maybe a little bit of a bump on the femur, but really not too much on the acetabulum. So because this area of the acetabulum bears a fair amount of weight, we don't want to take down more acetabulum than we have to, because it's going to narrow that area of weight bearing. But what we do need to do is we need to prepare that acetabulum so that if we repair this labrum or stabilize this labrum, that we'll be able to get it to heal. So I'll kind of expose and show you here as we go. Our charge nurse just came in and was giving our anesthesiologist an earful. So what you see right here is this is the bone. This is the edge of the acetabulum right here. And she's got a little bit of a bump right there. And as we start to kind of transition down the front part of the hip, So you can see that I'm kind of working my way on this bone right here. Thank you. My PA Micah Clutter here is reminding me to take pictures. Some of you, if there's any Athletico people on, might remember her from being Trainer of the Year like 4 years ago, I think she was. Good. So I'm kind of working my way. So I really want to kind of make sure that I get to that area where that labrum is a bit angry. So you're going to find one of the heads of the rectus coming in and attaching onto the rim of the acetabulum here. That's what some of these white fibers are right there. In terms of pain after surgery, I don't need to get too far forward, and that I found that if we can stay out of that rectus some, that I think it decreases the amount of pain, especially that these young females get. And again, in someone that had a big bump on the acetabulum that we defined preoperatively, I would want to expose this rim a little bit more in order to make sure that I remove that bump. In her, this is more of a preparation for repair than it is removal. But so what you can see is if we look right here, this is the bone. This is the edge of the acetabulum that's transitioning off into the back side of the cartilage. So if we look right down here, we see that kind of that cartilage loosening. So this is the edge of the bone right here, back side of the cartilage. Here's the labrum right there. So that's pretty good prep there. And I'm going to work my way forward just a little bit more. And if you follow this pattern of instability, if you look at this wave sign on the cartilage, as I start moving more towards that 12 o'clock position, you see that it starts to look a little tighter. And then right about this area right here, that cartilage isn't moving too much. That labrum is pretty stable. So the area of injury or issue goes from right about here, kind of right about down in the front, which is going to be a 2-anchor repair. And then the interesting thing about this is I'm going to really take a good look at the femur once we start moving around, because I want to see why she's getting some of this impingement. This is probably one of the hardest questions in hip arthroscopy or the treatment of hip issues, is that, yeah, on her MRI, it says that she's got a bit of a tear of the labrum. Bone looks pretty good, but why is she getting this bumping that's causing this loosening of the cartilage? And that's what we don't have the answer for. In people that have a cam lesion or a big bump of bone on their femur, that answer is pretty obvious. But in someone like this, who things look pretty good, we don't exactly know why. And actually, this bump right here is probably her AIIS, which is her anterior inferior iliac spine, where the other head of the rectus attaches. And this is coming a bit closer to the acetabular rim than what I normally see. So I'm probably going to just take down a bit of that AIIS right here just to make sure, because in females, they can sometimes get some impingement and hyperflexion because they have more range of motion. Especially the dancers can get some impingement even though they have pretty normal looking x-rays. So Michael, okay, so this is something called a burr, which is like a little Dremel that basically is going to kind of freshen up that area. So I'm going to start right here. So you can see that was that area of the AIIS where I said, hey, maybe there's some impingement. It's definitely in the area where there are some issues, and it's definitely would go along with having some groin related pain. So this is burring down that edge. You see that there's some removal there of that AIIS. To give you an idea of size, this burr is about 5.5 millimeters. So you see that a lot of what we're working with here is pretty small. These aren't huge areas. So if that's a 5 millimeter burr, I'm maybe removing 8 millimeters of that AIIS right there. Give it a slightly better view. And this is I always say hip arthroscopy is like gilding lilies, is what I was told when I was training. And I'm still not exactly sure what that means, but what it means to me is that there's typically not an endpoint. So, with like an ACL or rotator cuff or something along those lines, we'll usually have an endpoint where we say, okay, that's repaired, that looks good. With hip arthroscopy, it's a lot of just kind of doing stuff and then checking it, checking again. And there's not one endpoint where you say, okay, that's definitively my endpoint. So it's always a balance between doing enough but not doing too much, especially in these young females. Now it's time to start focusing on the repair spinal needle. I do make a third portal to come in from the to come in for the repair, because it gives me a better angle on the acetabulum. So you see my spinal needle is a new portal that I'm going to make for that spinal needle. This is a passing device with the suture that's in it, and I'm going to go into this area. So here's where I think there's definitely some instability to the labrum, and this is where that labrum's a bit angry. And so what I'm going to do is I feel myself on the bone right there. Just going to come a little bit further forward from it. My goal is to really kind of get right where that labrum is, kind of right coming through the cartilage, and you slowly see that I'm coming right through that area, passing it through the labrum. And again, everything looks big, but it's relatively small as long as we're down in this area. So this is the fovea and what we call the ligamentum teres. Some people think the ligamentum teres provides some stability to the hip joint. There are some blood vessels that come in, but it's a connection between the acetabulum and the femoral head. So as we kind of pass here. Okay. Perfect. So I'm passing that that suture through the labrum right there, and then I'm coming in through my other portal, and I'm bringing it out. Both of them there. Yeah, go ahead, pull them so we make sure we don't unload. Good. Okay. And so now I've passed that suture through the labrum. This is what we call a knotless device. I've moved over probably the last 6 to 9 months to really using knotless fixation in the hip, especially in the front part of the hip. I think that there's some benefit to doing it because you don't have a knot stack then. So you'll see what I'm talking about in just a minute. So go slow, stop if I tell you to stop. Go ahead. Good. So we're drilling a hole in there. You can see the hole right there. Anchor. Yeah. Good. And so now we're loading an anchor that's coming in through. So you can see we put the sutures through that anchor right there. So we basically took the sutures that we placed, we put them through the anchor. And now I want to leave some slack there. Maybe pull a little bit more on that, Micah, just a hair. Okay, that's good. So there's my hole. Okay, go ahead. And we're kind of slowly tapping this in here. You'll see that it's reducing that down. Slow. That's good there. And now that anchor is in the bone and it's locking that suture in place. And then we're removing that here. And you can see that that's a nice tight repair of that labrum in that area to really improve the stability. Okay, go ahead. Oh yeah, keep going. It'll grab that other piece as we keep going. Keep going. A little bit more, keep going. A little bit, I just want to see a little thing that we need answered.
So we did have one question, would you mind explaining what kind of suture you are using to stabilize the labrum?
Yeah, so this is what we call an ultra braid suture. So it's a braided suture. And right here, what I'm doing is just removing, so you can see a little bit of that delamination of that cartilage in that area right there. So let me get to this, Phil, real quick, and then I'll get to the question. So in that area here, I just really wanted to make sure that I remove any kind of loose little bits of cartilage there or loose little bits of labrum, and that looks pretty good to me. So now when I push on this labrum here, and when I push here, you can see that there's really not much more, there's not a lot of movement of either the labrum or the cartilage behind it. So that's kind of the goal of this, is to stabilize everything there. So that all looks pretty stabilized. I'm pretty happy with how that looks. You know, this angry part of this labrum, we hope that by stabilizing it and removing some of the impingement will kind of heal itself, especially in a young girl like this. So the suture is what we call an ultra braid suture, which is a braided suture. It's non-absorbable. This particular type of suture is called tape. Let's come down on traction, meaning it's flat. That's why I like using the knotless anchors, because I can use this really wide suture right here, which, as opposed to just one small string, gets really good compression across that labrum. So this is a tape braided non-absorbable suture. the labrum will heal around it. So if you come back in for a hip arthroscopy, you can still find it, but you can see that it actually kind of grows into the labrum. So now we're letting traction down on the hip joint because we've now repaired the labrum. So now this is what it looks like once in a normal hip. So we've let traction down, and you can see that that femoral head now is sitting in that acetabulum. Gives you an idea of kind of how much opening that we had before. And so now we're going to be checking to see if there's any impingement. So this is the femoral head right here as we're kind of coming down. Let's flex up some. And you can see the capsule, you can see the muscles. The iliopsoas is going to be off. This is the muscular portion of the iliopsoas in the front of the hip. Keep going, Micah. And I'm just removing a little bit of capsule here so that I can see down into the neck. So this is actually the neck of the femur. Here's the femoral head. Here's the labrum. And I really want to, we're really going to be checking to see if we see secondary signs of impingement or what things look like in this area. This is kind of coming down into the, what we call the lateral, or kind of the 12 o'clock part of the femoral head neck junction there. And this is coming down here. Here's the neck. So this is the neck of the femur. So if you look, and you know, maybe sometimes I make this up in my head, but again, I need a reason why she's having some of that instability in that cartilage there, because repairing the labrum, I think, is great, and I think it's going to make her feel better, but I need to be able to prevent this from happening again. And so if we really get critical and we look anteriorly here, here's the labrum, here's the femoral head. This is dropping off nicely in this area. As I come more lateral and I look right here, as I look right here on the femoral head, and as I follow this down, you can almost see that there's a little bit of a ridge right in this area right here, where it doesn't drop off quite as much. If I come further down, back down in here, that's actually a good view. Those white things right there, these are all the blood vessels of the femoral head. So there's about 12 of them that come into that area, but that's the blood supply of the femoral head. So if I'm going to be doing any resection, and we certainly won't need to go that far in this case, I always need to make sure that we preserve those vessels. So what I'm going to do here now is to say, okay, so here's my labrum. This is where I think my ridge is a bit. Even though I'm not seeing a ton of it on x-ray, I do feel like I see something here. And that in a flexion and internal rotation-based position, which is where you're going to get impingement, it also correlates that ridge area with where my repair was and where the instability of that labrum and that cartilage is, and how angry that labrum looks right there. So to try and prevent this from going forward, we're going to resect a little bit of that ridge. So you see a lot of the white cartilage that's on the bone there. This is what we call non-articular cartilage, meaning it doesn't provide, it's not a weight-bearing area of the hip joint, which is why it's okay to resect some of this. So let's redefine here. Okay, so here's my ridge. We're in about 45 degrees of flexion. So I think if I'm looking critically at this, if I see where the drop-off is in the front right about there, my ridge right here, I'm going to say, okay, I'm going to carry this line across. I'm going to carry this line across that ridge, following the contour of the labrum right there so that I don't over-resect or under-resect. And then this is where it feels like it starts to drop off a little bit more back here. So I'm not going to go too far this way, just a little bit. And then I'm removing the covering over that ridge because I want to get to the bone. And the burr doesn't do a very good job of getting through some of this cartilage. Making sure there are some vessels up front here. So if we see these way up here, these are some anterior vessels right there as they come across. This is down on the femoral neck right here. This is just a little bit of scar tissue. And then coming down laterally, here's our other blood vessels back down there that are coming up. So just kind of moving this. And if I'm going to do a resection, I want to make sure I take it back to the level of the neck here. Make sure I don't leave some ridge. So again, this is just removing just the covering of that bone and kind of identifying that area where I want to do just a bit of that resection right here. Good. Good, and then here's our burr back. And then in big kind of sweeping motions, I'm just starting right up at that ridge right here, coming down here. And then I'll kind of slowly work my way back towards the neck. Again, she's not going to require a lot of removal of bone. I just want to take it to kind of the level of what's around it. So you can see that now I'm getting to kind of where I felt that drop off was anteriorly. So taking it back to that level. Taking it back down to the neck. You can actually see, if you look, I always look for secondary signs, and right in here, there's a little bit of white. That white in the bone are really small cystic changes. Those cystic changes usually go along with some areas where there's some impingement. You know, if I really get to the next level on things, that area is really far distal on the femoral head neck, which means that there's sometimes some of that impingement that occurs in that area is because of that internal impingement on the AIIS, where we had that bump of bone before. So this would be someone that maybe doesn't fit into the traditional hip arthroscopy impingement pattern, where you have a cam bump that bumps up against the rim. You know, she might be getting some impingement onto the AIIS. And so as I kind of resect back down in this area, making sure I'm taking it to the neck. I think that looks good, Micah. Stacy's nodding her head, which means she's approving. Stacy's a woman of few words. If you ever meet her, she'll wave to you. And we should give credit to Dr. Scott Weintraub, one of the best anesthesiologists this side of the Mississippi River. But in all reality, doing this in what we call a dynamic exam. So the dynamic exam is going to be, Mike is going to take the hip out of our hip distractor, and we're actually going to move the patient into functional ranges of motion to kind of see what happens. We'll get a better understanding of what's going on. Okay, go straight flexion, please. So she's going straight flexion here. It's going to get a little tight in here. She goes to more degrees of flexion. So she's about 90 degrees of flexion right there. Let's come down just a little bit and then do some internal. Good, internal. So now she's internally rotating. This is kind of an impingement position. Keep rotating a little bit more. You see our resection area right there. So, you know, in this internal impinge, so she's about probably, 30 degrees of internal rotation right now. Come back just a little bit, Micah. So in this position of impingement, you can see that that area of resection that we did, if there was a ridge there, would have been bumping up against that labrum. That looks pretty good. I'll probably smooth things out a little bit more, but let's come down into extension. And so now we're going to look down the back part of the hip back here. And let me just resect a little bit right there. Just going to smooth things off, coming down the back side of it. Get the speed stitch ready to go, Stacey. And the cannula open. Okay, come down a little bit more, and then we're going to do some abduction. So now this is an abduction. So this is kind of looking for lateral impingement. There you go. So she's bringing the hip way out. So right now she's on 50 degrees of abduction probably. And what we can see is that probably not a lot of impingement in that area, but there's definitely no instability of that labrum that's occurring with that far degrees of abduction. In these young girls, I want to make sure that I don't over resect, because we talk about a fluid seal, and I think you see it well here. You see that that labrum really cups that that femoral head. And that provides a kind of a closed environment within the hip joint that allows fluid to remain there and help with lubrication. If I over resected all the way up to, say, right there, and now abduct, Micah, and that area that I resected then would go under the hip. In people that are having impingement, you need to do that. In people that aren't having impingement, you can theoretically violate that suction seal, which we don't know the downside of that, but we kind of like, especially in someone that's her age, we want to keep things as anatomic as possible. Let's come back out of the abduction there. Let's come up into a little bit more flexion. Good, good, great. So all this is kind of the non-articular area here. Looking down the resection here, I think that looks pretty smooth. Just for this white here is the one side of the capsule. This is the other side. Twist the cannula back some, Micah. So what I'm going to do is I'm going to put this special instrument here, kind of on a good part of the capsule there, passing it through. Hold the camera. Hold that there. There's been some research that shows that with capsular closures, it does decrease pain postoperatively. I would say we close the vast majority of our capsules. In males that have really big cam lesions that have bad motion, we'll sometimes leave a portion of these open. So you see the other side of the capsule there. in order to potentially improve some of their motion. Just passing that. Hold the camera. You have a knot pusher for me. Hold that. Okay. So you can see now that there's my suture across the capsule. I'm going to get a nice closure there. Good. And closing that capsule back up. And then I'm just tying this knot down here. So, you know, if I had to predict her future, the hope would be that with some of this removal of that bone, stopping some of that impingement, improving the labrum, that it's, you know, theoretically going to hopefully help make her feel better now, but then also prevent potentially some issues in the future. This is kind of, so with that, I think we can kind of start to close things out here, Bill. I'm just going to throw one more stitch in and then we're just going to move into closure. Are there any final questions?